Hi, welcome back to JAMA Network Open Live. I'm Seth Truger, digital media editor for JAMA Network Open.
Hi, hope you had a nice break. I'm Mike Berkowitz, electronic editor for JAMA and the JAMA Network.
Right. As some of you may have seen on Twitter today, my daughter was visiting this morning. Unfortunately, she had to go, so she is not here for the broadcast. So sorry to let people down.
Our disappointment, she's gorgeous.
Oh, thank you. She's a lot of fun. She likes science, and she liked the hats. Every time I talk about the video, she says, "Did you guys wear the hats?"
For longtime viewers, we wore hats back in December during the Chicago's polar vortex. They're behind us, and we'll wear them again should the weather permit.
When the weather permits.
Yes.
Yeah.
All right. Yeah, what do you got?
So diving into the first paper, the feasibility of core antimicrobial stewardship interventions in community hospitals by Deb Anderson and colleagues. And we've got first author, Dr. Anderson here. Deb, welcome.
Hi, thank you for having me.
Great. So tell our viewers a little bit about yourself and what you did here in the paper.
Sure. My name is Deb Anderson. I'm the director of the Duke Center for Antimicrobial Stewardship and Infection Prevention. Been an infectious disease doctor here at Duke for the last 12 years, with a specific interest in developing strategies for improving the way we use antibiotics and preventing multi-drug resistant pathogens and infections from happening. One of the unique things that we have here in our center are programs that focus specifically on community hospitals. And so we learned a lot about some of the differences that are required to perform infection prevention or antimicrobial stewardship in those settings. But there's obviously much more that could be learned and needs to be learned. And that's what led to the study that we just recently published in JAMA Open. The bottom line is that most of the data that's presented on antimicrobial stewardship is from large academic hospitals like Duke, not small community hospitals. And so while CDC has specific recommendations about what they call core stewardship interventions, it really was not clear to us whether or not those were really doable in some of the smaller community hospitals that we engaged with. And so we enlisted 4 of our community hospitals and in a crossover study design, basically put in place a couple of different, again, core CDC interventions, really just to test feasibility. Could we really pull these off? And as a secondary goal, try and see if they led to any impact on the patients that were seen there during the time.
Yeah, and as someone who works primarily in the big ivory towers like Duke, I find it interesting when this stuff is tested in community hospitals because we've got 24-hour pharmacists. We've got tons of residents and research assistants and all sorts of hands on deck to do this kind of stuff. It's always easy for the ID section chief to say, sure, just page the fellow if you need something.
Right, of course.
If you need approval. So this kind of real world evidence is always meaningful to me. So what were the 2 different interventions you tried?
So the core interventions that we first tested, one is called pre-authorization. It also goes by that less favorable name of restriction. That is, you can't use an antibiotic unless you get some form of approval. And the second one has a few different names. The one we've called it is post-antibiotic prescription review. And the idea behind restriction is you can't use it. You have to get an approval. The idea behind the behind the review approach is that after approximately 2 to 3 days of use, some more data has come in about the patient, you see how they're doing, then there's kind of this interaction between a pharmacist and the clinician to say, hey, does this antibiotic need to be used? And it really leads, frankly, to one of the first and key conclusions from the study is that restriction or pre-authorization just was not feasible in our 4 community hospitals. When we tried to go all the way through the approval process, it really got hung up in the medical committees because these are hospitals that don't have infectious disease backup or infectious disease expertise. And the clinicians felt very strongly that in the absence of that, they didn't think that that point of impact, that point of input was going to be useful or helpful for their practice. And so we modified that. So in the paper, what we describe is actually a modified pre-authorization. We've also called it, first dose is free kind of approach where you put in the order, they get a dose of antibiotics, so you're not holding up the care that's being provided, but you can then take a pause and have the pharmacist interact with the clinicians at that point.
And to be clear, these antibiotics, these are vanco, piptazo, and carbapenems. There's not all antibiotics that physicians are prescribing, right?
Very important point. Yes, that's absolutely right. We called those our targeted antibiotics. And that's actually pretty close to in line with what most stewardship teams do. You just can't possibly intervene on every single antibiotic order that's put in because, again, the data suggests upwards of 60% of hospitalized patients are going to get at least one antibiotic. And so the volume's way too high. So you have to find these targeted drugs that you really want to go after. We chose these three. That is a combination between frequently used and then ones we want to preserve, right? So vancomycin, very commonly used, same with piptazo. And then carbapenems are those, last but very big guns that we want to use only when absolutely necessary. So those are the three that we chose to target.
And let me just ask, the restricted program or the full prior authorization that you judged not feasible or wasn't supported in these community hospitals because there was no ID physician, a pharmacist could recommend guideline recommended alternatives to these first line agents, right? So was the issue that physicians didn't want to be listening to non-physician recommendations for antibiotics?
I think that was part of the issue. In fact, as part of the approval process, we had very detailed and specifically outlined, here are what are going to be the points of interaction. If you need to use vancomycin, then these are going to be the questions that will be asked. And if you don't meet the criteria, then in that setting, you really shouldn't have approval. And the pushback was really, you're talking about something like 24/7 coverage, requiring input from a non-physician. Those were some of the sticking points when those discussions came up.
And was a first dose free model then, did that buy time for an ID physician to be on call or available within 12 hours, for example, to give that kind of relationship between the two clinicians? Or am I over-interpreting the situation?
The scenario you describe is theoretically possible, but you have to have those ID physicians in the community hospitals. And the majority of community hospitals do not. In fact, in the 4 community hospitals that we engaged in for this, one had an infectious disease physician that was routinely available. A second had an ID physician, but he's more like a regional doc. He came there once a week, basically. And so the amount of exposure and accessibility was definitely, anywhere from 0 all the way up to, near, full time. And so as a result, in most scenarios, again, our scenario there is not unique. Again, I think that that's a specific issue across the board when it comes to these community hospitals. Mm-hmm. But as a result, in our study, yes, we basically had to concede that was not going to move forward and kind of figure out this second strategy or modified strategy to make it work.
Yeah, that reminds me of when I was a resident in an ER, big urban academic center in New York City, and we had piptazo was restricted until 5:30 p.m. where we had to get approval. And after 5:30, we were smart enough to choose that. And it's even there with fellows with big ID faculty, it was hard to get just the kind of hands on deck available to make those approvals.
Right.
And it's realistic. One of the things you mentioned, the fact that it's just the 3 drugs found, what was probably my favorite of the secondary outcomes you found when you surveyed clinicians about what they thought about it, that a third of the clinicians admitted that they chose antibiotics that weren't part of the study, so they weren't going to get criticized, which I think I'm kind of optimistically cynical about, because on the one hand, that means that they're just trying to skirt the question. On the other hand, that means they're not using the big guns that they're not supposed to be using unless you really need to use them, which is great.
Yes. I completely agree on both of those points. We wanted to very specifically ask the question because we thought it would be at least a little bit provocative. Mm-hmm. Our sense is that probably if you didn't use those, just as you said, then that maybe means you use something that was a little more narrow. And hey, that's part of the goal perhaps in some of these types of interventions. So we thought that was an interesting finding as well.
But to be clear, the modified prior auth, the first dose free and the first doses free, both programs you were able to get buy-in from in these community hospitals did lead to more appropriate prescribing. Is that fair to say?
I think that's fair to say. And if you get into the, some of the real details within the paper, you see that the different types of interventions really found different types of opportunities. And so for the pre-authorization, that was modified. There were a lot of suggestions related to dose and maybe optimization of the use of the antibiotic, but not as much, this doesn't seem like the right antibiotic type of interactions. Conversely, on the post-prescription review, there were many more opportunities to say this is not a necessary drug any longer, right? Your cultures have come back, the patient as well, whatever the rationale might have been. And I think in the stewardship world, we like that type of interaction much more than just, finely tuning the dials with a dose change. We like the larger changes of you just don't even need this, or you can really de-escalate to something that's much more directly focused on the infection you're dealing with. And secondarily, then with that approach, that's post-prescription review, we actually did see a signal with the antibiotic utilization data, and that there was a decreasing trend towards less antibiotic use in that arm of the study.
Yeah. So I guess the fundamental question to me, and I don't know the answer, love your opinion on it, is the whole goal here is to halt the progression of antibiotic resistance or antimicrobial resistance, and is the trade-off of the logistics of getting this kind of approval through versus letting patients sneak through with maybe a day or 3 days of inappropriate antibiotic, is that trade-off there? Or are we still going to be causing substantial resistance?
I think it's a reasonable question. It's one of those scenarios that stewardship in general, obviously the goal is not zero antibiotics. We have to use antibiotics. They're critically important. Everybody certainly understands that. But I think any type of movement towards making them more appropriate is ultimately the goal. Mm-hmm. And I think based on the conclusions from this study, some other of the stuff we've done in our hospitals, basically we've come to the conclusion that any one of these interventions, if you can demonstrate that it decreases utilization, then it is a valuable enough that it can in fact tip the scales towards decreasing the pressure. It's not going to eliminate the pressure, but will decrease the pressure on driving the drug resistance and development of superbugs. And so we think it's a reasonable trade to make. Have a couple days, we'll reassess after 3 days. You've got more data. There's more objective information that you can use to make a decision at that point. And as a result, it was a more opportune time to engage the clinicians.
Across our 13 JAMA network journals, we're seeing an increasing amount of material about mobile health and telemedicine. And I don't know, but it seems to me that this seems like a setup for these community hospitals that don't have ID docs on site to be able to have either an authorized app or an ID doc available by video conference, for example, in a structured way to provide the service. The question is open about whether a full prior auth is going to do more than modified prior auth, for example, in this as you implemented here. But I'm wondering whether that idea has gotten any traction in the infection control community, whether it's anything you know something about.
Yes, great question. And you are right. There has been movement in that direction in infectious disease and clinical care, as well as in stewardship, and just those more small, perhaps, points of interaction. There's a group in California, for example, that has published some papers in just that, of using telemedicine approach to impact antimicrobial stewardship interventions and impact antibiotic use. We here at Duke are in the early stages of trying to put together telemedicine for clinical infectious diseases. And if or when that's in place, we think that there certainly will be some opportunity to use that for some other uses like stewardship as well. You can go to your ID Week, your big conferences in infectious diseases, and you will definitely find posters and abstracts and presentations of people trying to use telemedicine. Because I think, like you said, it makes a lot of sense. You got to get there somehow. What better way than perhaps on some kind of screen if you can't be there personally?
And I guess the other challenge, even with telemedicine, is to create this process, even though we can all agree with it cognitively, is yet another hassle for clinicians to go through, right? It's some other authority, or maybe anonymous authority, they need to consult before they can make their clinical decisions for their patients and move on to the next patient. So, it seems to me the burden for the infectious disease community is integrating in a way that's kind of sympathetic with the local cultures and gets buy-in. I'm not telling you anything you don't know, but
I'm an optimist, and I see it as not as someone taking my agency away, but someone else making decisions so I don't have to, and that's one less decision I have to make. And I like your culture pun.
Right, but if it takes an hour and a half and
right.
you're there,
Right.
You're rounding for that 30 minutes,
yeah.
It's pretty
Well, that's why I get the first dose. I'm in the ER.
Okay, yeah, okay. Right.
And I don't round.
So, yeah.
All right. Well, thank you so much for joining us. Great paper. Thank you for sending it to JAMA Network Open.
Yeah.
My pleasure. Thanks so much.
Great chat. Thanks.
Take
Thank
care.
you.
All right.
All
so
right.
We skipped last week, so we're going to do a giant TOC rundown, not as big as some prior ones we've done.
Okay.
But we're going to start with this is a systematic review meta-analysis of MRI for targeting biopsy versus systematic biopsy alone in the prostate cancer diagnosis.
Okay.
I'm definitely not an expert on prostate cancer diagnosis,
Right.
but apparently, or the way I understand it is a lot of the, there seems to be a lot of overdiagnosis in prostate cancer, especially with screening, PSAs, et cetera. Systematic biopsy of just kind of doing a bunch of kind of anatomic biopsies helps push that envelope of overdiagnosis. What they looked at here was 7 different RCTs with 2,600 patients where they did an MRI first before they did the biopsy to then target the biopsy for specific cores to look at and not just do kind of a broad shotgun approach to looking where things are. They found that improved detection of clinically significant prostate cancer reduced the overall number of core biopsies and may avoid unnecessary biopsies as well, which all sounds good.
Right. It all sounds good. I think this is multiparametric MRI, which I don't know that much about, but reading closely, it's the addition of contrast. And so we have known through individual studies, this is a meta-analysis, that it seems to be able to better target biopsies so that you increase the yield of clinically significant biopsies. The issue is when you do blind 10 to 12 kind of peripheral field biopsies, you get lots of prostate cancer that may have contributed to elevated PSAs. But many of them are low-grade Gleason scores that don't end up progressing, and you put patients and docs in the position of sitting with a cancer diagnosis that probably won't go on to be clinically significant, but patients and docs want to do something. So the MRI helps target that, and it's the addition of contrast that seems to be the advance here in clinical practice. And they did a few different, they looked at a few different models, which was including MRI with targeted and systematic peripheral field biopsies. All of it sounds good in that it seemed to increase the yield of prostate biopsy procedures for detecting clinically significant cancers.
Right. And to me, the combination here is, the question is whether doing more work up front, so doing these MRIs, which are, more work, more tests, et cetera, does that, is that a stitch in time that saves 9 down the road? And are you, then going to do less chemo, less prostate resections, et cetera? And the fact that they were able to do this and basically improve, maintain sensitivity without decreasing specificity. So, better babies, less bathwater, always good.
Right. Okay.
All right. So moving on. This one's a little more in my wheelhouse.
Yep.
So this is the Pulmonary Embolism Result Forecast Model for Computed Tomography Clinical Decision Support. Basically, the idea being using machine learning to try to look at the charts to see if the computer AI is smarter than just simple clinical prediction for doing CTPE imaging, CTPA imaging. So great acronym, PERFORM. Always nice. Always love good acronym.
Yes.
They use the electronic medical record from 3,400 scans from 3,200 patients, which is I always love when there's that little mismatch, from Stanford to derive use machine learning to kind of derive what it was doing, validated on 240 separate patients from Duke. So kind of got an external validity there. Because there's a lot of differences in patients and differences in how people practice, how people assess risk, et cetera. And then also separately compared it to 200 other clinical scorings in outpatients. The area under the receiver operator curve on the initial data set was 0.9. It dropped to 0.7 at Duke. So still good, but not, certainly a little worse when they went to a different data set. Some of the numbers that were kind of real world was they basically, the machine learning would have been able to eliminate 440 out of 140 negative exams from Stanford, while only missing 2 PEs. Similar numbers eliminate about 70 out of 140 from Duke, while missing 4, or 150 out of 244 while missing 15. So there is a trade-off between sensitivity and specificity. Doing less scans, good. Missing PEs, probably not as good.
Right. Did they compare this to the Wells score and Geneva Revised score, and it performed better by area under the curve?
I know they compared it. I don't remember the numbers.
Right, because that's the issue. Yeah. I mean, because it's not so complicated to do that. You can say throw it to the machine.
Right.
But I'm not sure that I'm not convinced that there's that much of a gain in a machine if it's only a little bit better than taking 4 variables and getting a risk score. Right. And again, this isn't necessarily for the diagnosis of PE. This is kind of at least framed in this study, is a tool for referral for CT scans. So you don't, with the intent of reducing negative CTs.
Right. Yeah.
Right.
I think down the road, what I could see this eventually becoming, this is a step towards, is when I'm worried about PE in a patient, I don't order a CT or order a D-dimer. I click, PE diagnosis, and I click the button, the EMR churns a bunch of numbers based on all the different clinical information and says, this patient's low risk enough, D-dimer's fine, or they're so low risk you don't need to do anything, and is using much more information than I can use from a score like PERC or Wells or Geneva, and theoretically could outperform that. It seems like we're taking steps toward that, but we're not there yet.
Yeah, and what was interesting to me is that a lot of these AI studies, we see that these algorithms are doing well on images. So I entered this thinking, they're going to be looking at CT images to see whether if the machine does better than pathologist or radiologist in diagnosing the findings of PE. But this is prior to the CT scan. So just an interesting way of adding a picture element to this growing trend towards using these algorithms to figure things out for us clinically.
So maybe someday.
Yeah.
Yep. All right. Next up, this is trends in medical aid and dying in Oregon and Washington. So Oregon and Washington, 2 states in the U.S. Who are the first 2 to have physician-assisted dying or physician aid in dying programs. There's lots of different names for it. There's a big discussion of it in the embedded commentary. Many of these names are used specifically to frame the debate in certain ways, which the commentary gets into, which is interesting to me. But basically, they looked at, because these 2 states had the longest legal programs for it, they looked at just how it was used, what the rates are. You can see the graph in the visual abstract that we can show. But basically, there were 3,400 patients since I think it was 1998 who received prescriptions for medical aid in dying. Only 76% of the patients actually took the medication and actually completed death, which is interesting to me.
Well, some of them may have died before. We don't know that.
That's potentially true. Yeah, that's a good point. And then some of the stats. So of the 2,600 who died, 76% were for cancer, which makes sense. 10% for neurologic illness, so things like advanced Parkinson's or debilitating strokes. 6% lung disease, only 5% heart disease. 3 out of 4 of them were enrolled in hospice at the time, and 4 out of 5 of them died at home. And you can see the rates are kind of just slowly increasing in kind of natural curves that make a lot of sense. They're not answering all the big ethical questions about this, but there's some interesting information here about how this is being used and where things are going.
Right, and the thing that was interesting to me is that if I read it correctly, I think 96% of people who participated were white. And so that may completely match the demographics of Washington State and Oregon, but there are not large communities of color taking advantage, if that's the proper phrase, of medical aid in dying. And it fits my common conception of minority communities being more distrustful of the medical establishment in terms of looking out for their interests in healthcare settings. So I don't know whether one can fully read that out of these data, but I think it's something to keep an eye out for communities, clinical and research communities interested in this topic.
Yep, we've got a couple of new viewers, Abdul Al-Hafani, National Black Channels, and Lena Lu 8. Welcome. Our next paper that we have. So this is another, we talked about, before I jump ahead. So cardiovascular adverse events associated with BRAF and MEK inhibitors. So another systematic review and meta-analysis. 5 RCTs of these 2 chemo drugs used in melanoma treatment.
Right.
They are, I believe, they're both antibodies.
They are not. They are not antibodies.
I don't know.
They're MIBs rather than MABs.
Oh yeah,
right?
I don't know. They're both drugs that are used in melanoma, which is not something I do.
Right.
They all ended in INIB, but basically they're 2,300 patients, and basically there's concern with these 2 together. They were increased cardiovascular events. They basically increased the rates of PE with a risk ratio of 4, decreased ejection fractions, also relative risk of 4 with which was worse in younger patients, I believe, and also increased rates of hypertension with a relative risk of 1.5.
Right. So these newer agents have cardiovascular adverse events, and as our treatments get effective, I may not be telling you more effective, and I may not be telling you anything you don't know. As patients are surviving or living beyond their cancer diagnosis, there's a whole new area of oncocardiology because a lot of these agents have cardiac toxicity, and there are even subdivisions within departments of oncology meant to and or cardiology meant to deal with the specific long-term complications, cardiac complications of cancer treatments.
Yeah.
We had a great review in 2016 in JAMA Oncology, which was kind of a shot across the bow. It reviewed where where things were, and there's lots of papers coming in about this.
It's interesting to me how we're kind of, there seem to be a lot of pieces like that out of the puzzle coming together of patients who are surviving previously unsurvivable problems. There was a JAMA Network Open paper a few weeks ago about, I think it was adults who had survived childhood cancer. There's another one, I think, adults with congenital heart disease that had normally not been survived. I've heard previously before about problems that people with problems like Marfan's have growing up there now. Instead of, they got their aortas fixed before anything happened, but now are having medium-sized artery problems. I read something, I forget where it was, a few months ago about the burden of opioid addiction after curative cancer, just a problem we didn't have decades ago because people weren't surviving cancer, plus we weren't using opioids as much. So all these kind of complications of treatment. I'm still an optimist where these are good problems to have rather than dying when you're very young. But interesting world.
Okay.
So moving on. So this is an interesting survey on patient non-disclosure to clinicians. We had talked about that a few months ago on the broadcast here. This one is about for patients experiencing imminent threats. So the 4 threats they talked about were depression, suicidality, abuse, and sexual assault. 2 surveys, half of was from Mechanical Turk. 45% of these patients who had one of these imminent threats were withholding information from their clinician. And these were kind of the typical answers that we've seen before and that you would expect. The reasons they explained were because they were either embarrassed about having the problem, they didn't want to be judged or lectured about it, they did not want to engage in difficult follow-up. And not surprising, the odds ratio showed was about 1.7 female to male.
So are these omissions or are these commissions? What I mean by that is I ask you and you don't tell me, and that's in a certain sense kind of lying to me, or is it just you don't bother to mention it and I forget to ask?
To be honest, I don't know. I don't remember the paper that specifically, but it's that the patient had this information that they were a victim of interpersonal violence and did not bring it up to their physician.
Because I certainly can. It's easy to imagine that if the doc doesn't reach out, that I'm not going to say anything, or that, and I've mentioned this before, I need a long-term relationship with the doc to feel comfortable with him or her before I'm going to tell them about the stuff that's really upsetting to me.
And when we talked about things before, like screening programs, like there's a lot of things, like I think almost every patient in every ED is screened for depression. That's usually a triage nurse you met 15 seconds ago. You're here for another problem, and there's a battery of questions. All right, you're here for belly pain. What's your insurance? When's your birthday? How much do you weigh? And are you depressed? Obviously, a lot of the nurses are much better at that. And most of the best nurses get stolen away from the bedside and taken to triage or punished and put in charge.
But thankfully, they're no longer asking, "What's your pain on a scale of 1 to 5, and how bad is it?"
Now they ask 1 to 10. No, we still ask pain scores. All right. So next up, effect of bismuth subsalicylate versus placebo on the use of antibiotics among adults with diarrhea in Pakistan. And RCT. Interesting for a lot of reasons. In RCT, apparently this is a situation where antibiotics are used a lot in Pakistan for relatively uncomplicated diarrhea.
I think you can probably get them from roadside pharmacies too. Like there's... we're talking about antimicrobial stewardship in community hospitals. I mean, that stuff is available for purchase by anybody in developing countries.
So they had 440 adults. They randomized 1-to-1. It was adults who had less than 48 hours of non-bloody diarrhea, so relatively generally low clinical acuity. They're all from clinics in some of the big cities in Pakistan, and they followed them for about 5 days. And basically 16%, so 1 in 8 patients in the placebo group used antibiotics, and only 9%, so 1 in 11 patients in the bismuth subsalicylate group, which is the pink stuff, used antibiotics. So basically, I think this gets to, again, part of my cynical optimism that when we think patients want antibiotics for their cold, when we think patients want Norco for their back pain or whatever it is, they want something. They want a doctor who pays attention to them, who listens to them, who tries to address their concerns, and we cut the corner and go to things like antibiotics and pain meds. If I had bad diarrhea, I thought I needed something for it, and I thought I would have benefited from an antibiotic, and Eric says, no, what works really well for this is this pink stuff. That would make me feel better.
Absolutely. I love this paper because it's a clinical trial and because it's this really low-cost intervention for this really common condition, and it had a happy result, which is it reduced the use of antibiotics. It didn't necessarily look at long-term clinical outcomes, which I think is missing, but it's something I certainly want to believe in, that if we could distribute this as an intervention for diarrheal illness in countries that have a wide prevalence of diarrheal illness, this could be a huge public health change.
Mm-hmm. Yep. And again, I think we as physicians have a lot of burns on us, and a lot of us feel a lot of different pressures. But people just want antibiotics, people just want pain meds, and this helps reinforce. No, people want us to be doctors. So be a good doctor, and the world will be the path to your door.
Right. And this is an evidence-based way to move you in that direction.
Right.
In
next,
Pakistan.
Yeah, there you go. So moving from Pakistan to rural California, hospital utilization among rural children served by Pediatric Neuro Telemed. Basically, they looked at a bunch of kids who needed neurologists, who saw them from telemedicine versus in-person neurology, and it turns out that the people who used telemed did not need to be admitted to the hospital or go to the ED as much, so lower hospital services. There was some confounding because the people in rural areas were more likely to have non-private insurance, so public insurance, self-pay or uninsured, lower education and income, and obviously longer distances to big hospitals. But even when correcting for that, they use hospital services less. So basically, as we were getting at in the earlier segment,
I was going to say,
telemedicine services for specialty care has some promise.
Right. So there's no question that it's probably a good thing, and certainly broadband and mobile devices is going to make it more common. I think the issue partly is the structure of reimbursement and whether docs are going to give up their time to telemedicine, particularly if they don't have the support of broader academic medical centers that are developing these opportunities, and how insurers are going to pay. I worry a little bit about the absence of a physical exam. Some of that can be done. Certainly a history can be taken. Sometimes it's a physical exam. You may need a surrogate to do certain things. And I'm a huge champion of the physical exam. So I wonder what's lost in that. But the gain in health that will come from distributing this more to people who wouldn't otherwise come to the hospital is huge. And we're going to see more and more of this.
And you can do a lot of the neurologic exam, physical exam, without physically touching the patient. You can measure a lot of strength with pronator drift, things like that, et cetera. A lot of it is really visual. Unfortunately, not to me. I think one of the most important parts of the physical exam is the Reiki, the kind of laying on hands of the clinician, which helps build the relationship. And I'm not being hokey about that. I'm very serious about it. And I think that's both helps build a relationship and helps.
I'm smiling at the use of the word Reiki, which is Reiki, I believe.
Yes, which I am taking mostly from 30 Rock. So moving on. And one other issue with telemed that's interesting, that there's a lot of issues with state licensure, because basically all 50 states have separate licensing systems. So and a lot of places, like say cities, are on the borders of states. So it becomes really tricky as far as getting cross-licensing, because there's a lot of bureaucratic stuff. Very few states have cross-regulation. One of the things I can be cynically optimistic about here is that because there's a big bias towards rural stuff in general in Congress, this is the kind of stuff that gets a lot of attention there when it comes to medical or to health policy. So
great. Hadn't thought about
room
that.
for improvement.
Yep.
Last up, we've got the Association of Electronic Health Record Design and Use Factors of Clinician Stress and Burnout. They surveyed nearly
I predict an association.
There is. And so there's an association. They looked at some individual factors, nearly 300 ambulatory docs, primary care specialists, subspecialists, et cetera, from Stanford, the University of New Mexico, and Centura, which is somewhere in Colorado, Westminster or somewhere. I don't know. Sorry. I'm mostly ignorant about Colorado, despite doing a book report in Colorado in third grade. The big pros they found that the physicians liked, they can message colleagues, you can do home access, which I think is mostly a con, and you can share results with patients. The cons that they found and things affiliated with stress or associated with stress and burnout: excessive data entry requirements, note bloat, inaccessible information from other institutions, the balance between billing and critical care aspects of the note, and things that were actually painful, like posture and low back pain from using your computer too much.
So those were associated. Were there any protective factors or not really? Like if there was no note bloat, I like that phrase. I hadn't heard it before. Or an ergonomic workstation where doctors are less likely to be burnt out. Who knows?
I can't imagine anybody knows how an EHR would work without note bloat.
Exactly. Cut and paste, cut and paste. There was a piece of my mind in JAMA many years ago, well before my time here, that actually was a cut and paste essay to replicate what was happening in the electronic health records.
We had a resident was giving a conference a couple months ago, and it was an M&M case, and they're showing what happened. And when they go through the note, they hit the little filter folder that shows what was pre-populated.
Uh-huh.
And it's like, here are the actual parts of the note that somebody entered in.
Uh-huh.
That being said, many of us are savvy and put in things that are pre-populated on purpose that we do every time.
Uh-huh.
Not everyone's responsible, and there's a slippery slope and all that other jazz. But regardless, EHRs, there's good, there's bad, there's ugly,
Right.
there's bloat.
I think they are largely still built as billing mechanisms and not as patient care mechanisms.
Yeah, for the most part. There's a lot of headaches, but I think the easiest way to criticize or to defend EHRs is go to a place that uses an EHR when they're on downtime.
Mm-hmm.
And
Right. Yep.
It's terrible. Yeah.
Okay.
So, all right. Well, thank you for joining us. We should be here next week, probably Tuesday at 3 again.
Right, but I won't be here, so Seth's going to have maybe a special guest.
Maybe.
I think you've written Lady Gaga. We're waiting to hear from her,
We'll
right?
see. Yeah, I don't think Lil Wayne will be here.
Right.
Right. But thanks for joining us. Follow us on all your social channels, Twitter, Facebook, LinkedIn, Pinterest, etc. Of course, read these articles and more at JAMAnetworkopen.com.
And the latest podcast episode has a summary from editor Steve Finn and Fred Rivera on this antimicrobial stewardship article. They've kind of discussed some other aspects, and there's an invited commentary that we didn't mention associated with that article. So listen to our podcasts. Check us out every Wednesday and Friday mornings, Central Standard Time, Greenwich Mean Time -6. And I will see you in 2 weeks, and he'll see you next week.
Yep.
Thanks
Great.
for joining us.
Take care.